Welcome to the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. The views, thoughts, and opinions expressed on this podcast belong solely to the hosts and guests and do not necessarily reflect the official policy, position, or opinions of Orlando Health or any of our employers. And now, without further ado, let's talk hernias. Hello, and welcome to another episode of the Hernia Gods Podcast. This is your mere mortal host, Luke Elms, and I am joined today by Shirin Towfigh. We are so happy that you are here, and we are excited to get to know you a little bit better.
Thank you, Luke. I was so excited to get your invitation. I was waiting for it, actually.
Well, you can't invite somebody too soon because you have to have a little bit of credibility because, you know, you're internet famous. And so we can't just like pull out all the stops right away.
Well, I've been listening to all your podcasts. I've caught up. So
I really appreciate that. That means a ton.
Yeah.
Well, as we start all podcasts, as I'm sure you know, I love to just hear a little bit about who you are, where you come from, and how you got where you are.
Thank you. Shirin Towfigh. I'm based out of Beverly Hills. I founded the Beverly Hills Hernia Center kind of mid-career back in 2013 and never looked back. I do 100% hernia and hernia-related kind of surgery. I'm very excited to treat all different types of patients. I feel like my practice is a little bit different than the average hernia surgeon. I really enjoy the groin and pelvis. I also offer, hernias of all different types, abdominal, all the rare ones as well. But I like chronic pain. I like solving problems. Females, I have a lot of females. Most of my patients are actually female, which is not typical of a hernia practice. And yeah, I like everything related to hernias.
Was that always an interest of yours?
No.
Or was that something that just kind of you ended up in serendipitously?
I hate to admit this, but I hated hernias as a resident because I didn't understand it. I think the reality was I didn't like the exam down there, and I didn't understand the surgery very well, and it was not really considered something to aim for as a resident. I trained in the late 90s, early 2000s. And so when I came to graduate, I said, well, hernia is going to be like the most common thing I need to learn. So I really focused towards the last couple months to do as many hernias as possible, because then you're going to be an attending. Who are you going to rely on then? Mm-hmm. And my first job was at the county hospital at LA County Hospital, and I got bombarded with hernia complications, mesh infections, these big loss of domains. And it's a very resident-run, county hospital. And so there wasn't really an attending that owned those patients. And I felt bad for them, honestly. It wasn't like I had that much of an interest, but I just felt bad for the patients because I knew there's a treatment for it. So I started treating them, and the run's like, oh, Towfigh's okay with these patients. So they started, giving me more of those patients, and I started getting involved with the American Hernia Society, which I didn't even know existed until I started my first job. And, the rest is history.
Yeah, it's, I think people, you're talking about, you work mostly kind of groin hernias. I think people underestimate the complexity of those and how even the simple ones can be complex if you can't pick up on some of the nuance. And I only know that because I think that I'm just now starting to pick up on some of the nuance. But similar to you, when I came out into practice, I was not very confident with hernias in the groin. And towards the end of my last year of residency, I actually went to some of the attendings that did high volume lap TEPs. Mm-hmm. And I went to them and I said, I just want to watch you do them. Yeah. Because I think that I realized that there was a level of observation that I think early in training is really helpful. And then you go through this period of like learning how to do it. Yeah. And then after you learn how to do it, you have to learn how to do it well. And then all of a sudden I went and started observing some of the attendings when I was a chief. And then I said, oh, so that's how they make that look easy.
Exactly.
Yeah.
So the Whipple is like considered the most, like the elite of all general surgery procedures you'd ever do. Now it's mostly surgical oncologists do it or hepatobiliary surgeons do it. Mm-hmm. But when I was a resident, I did 22 Whipples. Oh. And I think I still hold the record for our residency. That's a number of Whipples done. So I was like, this is like the most amazing operation. And so when I went to interview for my first job, which was a general surgery, like acute care surgery job, they're like, if you were to do one operation for the rest of your life, what would that be? And I was like, oh, that's easy, Whipple. And they're like, yeah, you're never going to do Whipple here. How about hernias and gallbladders?
Yeah.
So, it's just not given the, I mean, today's different. People actually want to go into hernia surgery nowadays. But back then, it was not something to aspire to. It was mostly out of necessity that I started getting involved.
Yeah. When they asked me when I came out of residency, and it's still one of my favorites, if they had asked me that question, mine would have been a facial nerve sparing parotidectomy.
Oh, yeah.
I loved those cases for some reason.
Those made me nervous. Yeah.
I'm not. Yeah, I mean, I think I loved it because I wasn't the one that was the attending. There's a lot of cases I loved as a resident. When I became an attending, I was like, oh, this is terrifying.
Yes. Some people think of that about inguinal hernias. When I was at a different hospital, I was like the hernia person for that hospital. Mm-hmm. And everyone around me is like, we're so afraid to do hernias now because like you're here. And so we're like, before we would just fix a hernia, we wouldn't think about it. Now we're like, oh shoot, are we Towfigh? Are we using the right suture? Like, which mesh are we supposed to use? Should we do this lap or open? I mean, it was like, so they understood that there's a skill and a science to it now, whereas before there wasn't.
Yeah, and the idea of it just being a hernia is equally frustrating to me as saying it's just a gallbladder. Everybody that ever says that, I'm like, well, thanks. Now this case is going to suck. Yeah. But but the whole just a hernia, it's just a hernia until you have a problem, and then it can be, as I'm sure with your specialization in your practice, those can just go forever. I had a patient just even today that's suffering from chronic groin pain, and it's so multifactorial in this patient's case, and they're at their wits' end, and it's destroying their quality of life. And I'm trying to explain that there are certain things that I can help, and other aspects of it that I actually can't. That she has like a lot of different, even medical issues going on, and it's just a really tough.
Tough situation. Get suicidal. Yeah, patients get suicidal from hernia chronic pain. It's very serious. Mm-hmm.
Yeah, and people, one of the ways that I grew my practice before I even really started becoming higher volume in hernia was with pain control. And I was basically doing perioperative pain control using multimodality. But whenever you get into that space, chronic pain patients seek you out because you kind of speak their language, and a little bit of the fact that it's not just something like, well, I can't fix that, see you later. You're willing to like talk to them about it. But it's also, a lot of chronic pain patients, unfortunately, in today's world, have been caught up in the wash of a lot of the opioid minimization, which it has its own benefits and everything. But sometimes there's like these bystanders that get caught up in this, that you can end up having people whose pain is just neglected or undertreated, because I watch a lot of my colleagues and other people that kind of got really concerned about opioids. And so then they started to pull away. But if people don't realistically treat pain with something else, you can't just not treat the pain. And so these chronic groin pain patients, I feel for a lot of them, because you can tell it's just like an everyday thing, every movement, and it's brutal.
Yeah, having friends as like really good pain doctors that understand what you do is priceless if you're a hernia surgeon. Yeah, absolutely.
Yeah, we it's just and some of these folks, they have bounced around so much that by the time they get to you, they're like distrustful of doctors in general, because they've never had somebody actually listen to them. And so then you're kind of working on an uphill battle to really develop a relationship or a connection with them. So
yeah, I mean, some of the messages I always tell my fellow surgeons is, please don't discount their pain. If you're not the right person to fix it, don't tell them it's in their head, or it'll get better, or there's nothing wrong with you. Send them to one of us, that's actually interested to fix these, because you don't know what you don't know. And what you're telling the patient, there's no more hope for you. And that's just not right. Because almost, I would say, not only almost everyone, I would say like 99% of patients that have a hernia-related problem, their pain is curable. Like curable, not just like, oh, just live with it. But there's a treatment for almost everything, except the really like end stage, patient, which is very, very rare. So I hope that people learn to make friends. Like, I have people, even today, I got a text from one of my former fellows, asking me about a patient. Every day I get phone calls from people around the world. This morning I had a call from a friend in London who had a patient. They just want to ask me for help. And like, that's good to go and ask and get advice instead of just tell them to, not only tell them there's nothing wrong with them, but don't refer them out. Like that I think is a not good for patient care.
Yeah, there's a level of humbleness, and I think there's also some psychology for the surgeon as well, especially when it's your patient. And it's just tough. It's tough because I try to throughout periods of my life, I've not always held this specific point of view, but I'm trying more recently to just assume that people in general mean the best, and that they're doing the best they can. I've not always been so. I've been more negative in the past in my outlook on life, but but I think that most people just want to do the best, and it's really tough to see somebody who's having a problem, and you're sitting there going like, dang, they really wanted, or they came to me with this problem, and they've still got the problem. Is this a technical error on my fault? Or that was my fault. Did I miss something? The number of times that I see patients, it seems like recently I've had this run of patients who have lumbar back pain that is causing some major, like they come to me and they're like, I've got this groin pain, and then and they're like, and it's here, and then it radiates down the back of my leg, and I'm like, okay, cool. Like, wait, we gotta reset expectation. Let's see what's what here.
But hernias can cause lower back pain.
Sure.
You can fix someone's hernia, like, wow, my back pain's gone, or it radiates around to their lower back. So that that we know can happen.
Yeah, I try to talk to patients about pain, and I was just a patient I was talking to today. I said, just because I can't see something on imaging doesn't mean you're not having pain. Like, this is not the pain doesn't necessarily always have to have a physical finding associated with it. And pain can absolutely be occurring, even though the CT report reads, negative CT of the abdomen pelvis, and so it's tough because they're desperate, and sometimes the surgeon feels desperate to find an answer, and it may be just outside the scope of what you do. And so I did, even today, I said, I've got some people around the country that I know treat chronic pain all the time, that maybe that's somebody we should get a second opinion from if it comes to that. And so we're working through the process, but I do think it's a tough problem for the patient. And it also can be a tough problem for the surgeon if they're, well-intentioned and just really trying and kind of running into no success in any of the treatments.
And if your practice is one where you don't have the time to spend an hour or more with a patient going through their chart and looking at all the images and having your staff get all the back information and sitting down and really like going through the nitpicky of like their symptoms, there are those of us that do it. Now, I would also say, as general surgeons, hernia surgery is not considered like something to really focus on. That's true for other specialties too. And I think radiology does not really appreciate the importance of hernias when they look at images. Right. So 3/4 of CT scans are misread or not read at all for hernias. So the report alone is not adequate. MRI, ultrasound, these are all like half of ultrasounds are incorrect for hernias. So, these are things that, if you have a patient with the right story, right, like a good story for a hernia, and you examine them, and they have a hernia, fine, but sometimes you can't really see like a perfect hernia. Maybe they're tender where they should be, and then you go for imaging to try and maybe bring that story into fruition as a diagnosis. You really need to make sure that imaging is correctly read. So I learned to read it myself.
Yep.
What you can do is you can partner with a radiologist that you can sit down and review imaging for. But, it's unfortunate if, you do the right thing and you think of hernia and you get the right image, but then the report comes back as falsely negative,
Yeah, I read all my own
Yeah, it's great for
CTs,
you.
ultrasounds, and MRIs. MRIs I'm getting better at, and they're not the best. I don't read those the best. I used to have an attending that called them blurograms, and sometimes I feel like that when I'm looking at them. But the CT scans, I have to tell my patients frequently, and I've gotten to a point actually where sometimes in patients I know that there's probably going to be some disparity. Like it's not somebody who's half their abdominal walls outside the fascia, half their abdominal contents are outside the fascia. That's going to be obvious. I tell them like, listen, I'll look at it myself. Radiologists are looking for hundreds of different things. I'm looking for really a few much more narrow focus. And so I can focus on the things that I know I'm looking for. One of the things I did with one of our radiologists, which was really helpful, is he was a really, really great guy. Unfortunately, he retired. It's like it was a big loss for all of us. But I used to review the scans before and after with him. And then I would take intraoperative pictures and send them to him. And so he could see, and it was not just for hernias, it was for everything, but he could see the physical manifestation. So he actually got incredibly good at diagnosing internal hernias and closed loop obstructions, because then he finally understood about the pinch points and all that stuff and knew what to look for. And so then it would be like, well, he was like hyper aware of it. And so it'd be like 3 a.m. and I'm like, Richard, come on, man. This is not, he's like, I didn't like, be careful what you wish for.
Yeah, that's true. But in radiology, they don't really tell them what a hernia is. Mm-hmm. Sometimes they say it has to be like peritoneum going through. That's not true. Yeah. Or they, if it's really huge, sometimes they don't even call those, or for the abdominal wall, they call it diastasis when we know it's an incisional hernia. Right. So, you have to understand the weaknesses of radiology sometimes and advocate for your patient.
Yeah. Something that you have kind of in your career path. First of all, where did you do your training?
UCLA.
And then when you went through, you said you went kind of in more of an acute care job at the county hospital?
This is before there was such an acute care fellowship. So at the county, Tom DeMeester was our chair. So he didn't believe in laparoscopic surgery. He's like, that's a technology, not an organ. So everything was organ-based. So we had thoracic, breast, hepatobiliary. We didn't have surgical oncology. It was like colorectal. It was organ-based. He was foregut.
Interesting.
So MIS, laparoscopic, like MIS did not exist. Yeah. So MIS became like at the county side, it became the kind of everything non-trauma. So if it wasn't a trauma patient, it went to MIS. We were the general surgeons. So if it was a bowel obstruction or hernia, we would try and do it laparoscopically. Robot was not available back then. And then like bariatric kind of fell under foregut. So that's why. So technically we're acute care surgeons, and the trauma people did their trauma, and we did what's called non-trauma. So we kind of just showed up, and whatever came through those county doors, you took care of it.
Here it came. Yeah. We and then you ended up in. You said it was 2000. What year was it? 2013 that you ended up going.
Yeah, 2013. I opened my own practice. Yes, went to private practice, solo. Love it.
How scary was that?
Never scared.
Never. No. You were just ready to roll.
I couldn't wait. I'll tell you, you can't do it coming out of a county hospital. That does not prepare you for private practice at all. Right. But my second job was at a community hospital, Cedars-Sinai Community Hospital, but very kind of academically inclined. That's why they hired me. But you get exposed to a lot of private practice doctors and practices, and you kind of start dreaming about what you can do without the auspices of like a boss telling you what to do and what not to do. So I loved it.
And so did you have like a business mind before going into private practice? or was that something that do you feel like you've developed it? I'm assuming that you have.
Yeah, I cultivated it for sure. I had former residents that were very successful in private practice that helped guide me. I read a lot. And by that time, I already had like a name. So I was able to kind of bank on my reputation for people to refer to me. So I didn't need the institution's name to gain patients. They were sending them to me because of me, not because of where I practiced. So that's when I noticed it was time not to kind of be hindered by the limits of an institution.
And I'm assuming you recognize that. I would assume you recognize that you're the brand, and so when you were at Cedars-Sinai, or even all the way back to the county hospital, did you recognize that building your own like personal brand was integral to the success of your career, or was that something that kind of came to you as you were moving into that private space?
Correct. At the county, you're just there to take care of patients, and your academic side was there to promote the institution. So wherever you went, said USC, Keck USC. Same with Cedars-Sinai. In fact, I was hired specifically to take my academic kind of potential and help spread, the name of Cedars-Sinai as being associated with what I do, and that was one of the reasons why I was hired, was to kind of elevate the academic output of the hospital. And you don't really think of it. And then social media came around, and I was like very anti-social media. And Brian Jacob, who you interviewed, I think he was your first interviewee. Was he your first?
He would have been episode 6, I think, actually.
Oh, 6, okay.
Haney was my first, and he felt every bit of the rookie behavior.
So Brian called me and said, I have a Facebook group called International Hernia Collaboration. Can you sign up and be a member? And I was like, I don't have a Facebook account. And I was like so anti-social media at the time. Mm-hmm. I want to say that was 2006 maybe, or 10. Yeah, 2006, I think. And then for him, right, I opened up a Facebook account, and then I started getting involved in like social media, understanding branding, and then I started posting on social media, not just using it to get on the IHC Facebook group. And I became more and more into it, whereas now I have Instagram, Twitter, YouTube. Like, I'm very involved in social media, and I understand how that helps kind of promote what I love to do, which is surgical education and kind of educating patients, educating surgeons, whatever it is. But it was really Ryan that kind of showed me social media, and then through that, the branding kind of idea started to percolate.
In looking at your social media presence, it comes across to me that it is something that you feel passionate about, because there is a strain of empathy that comes across when you're connecting with the patients on like your Q&A sessions on Hernia Talk and all those things, that it seems like you're really just very, very passionate about getting the word out there and reaching some of these folks and trying to really help. And do you feel like that's something that you're passionate about because you feel like it helps you kind of magnify the effect of your expertise?
Well, thank you very much for saying that. That's definitely how I hope to come across. Mm-hmm. I do feel in order to be a good doctor, especially dealing with chronic pain patients and, revisional hernia surgery, et cetera, that empathy is part of your strength of being a good doctor. Mm-hmm. The YouTube part where it's like this, right? So it's video, talking, engaging with others. I feel like that has really helped not just me, but our specialty. So right around when I started the YouTube, which was right before at the pandemic, 2020, we were like at the height of so much negative press about like doctors are horrible. You're killing people by putting mesh in them. Mesh is evil. Doctors who put mesh in are evil. And I was on Twitter mostly answering these people, and man, the backlash I was getting was like stressful, and it was just they didn't even know who I was, these people. And I in my own heart knew that I was doing good with my patient population. And then these people were calling me names, and like, because I was the most vocal on social media about hernias, and I was trying to balance between understanding what they're trying to say, but also instilling some science and data to try and counteract what they're saying, so that, all these patients aren't truly believing that we're killing everyone. 100% of patients don't have chronic pain or bad outcomes. That's just not, like, we would never do an operation if everyone died, like that's not what we do.
Yeah.
So when I started Hernia Talk Live, which is the video component of, I had the discussion forum forever, herniatalk.com. That's free, people can talk, share, whatever. When the YouTube video came out, I started hearing very positive, wow, Dr. Ramshaw was so caring. Wow, Dr. Jacob really put a lot of thought into his care of patients. And I felt like that exposure of our hernia specialists and our fellow colleagues to the general population kind of softened us up a little bit. They could see that we do think we do, we're not just like getting, quote, paid by industry to put mesh in, like all this kind of completely not factual stuff that you read about on some of these forums. And they started saying, oh, I saw let's say Dr. East. I'm going to go to her now because she really came out as like very caring and understanding. So I felt that the tenor of that also in the Facebook groups and social media had dropped, that I wasn't reading as much negativity and hate against us because I was humanizing us on video. And that's, I think, the best part of what I enjoy and what I hear as feedback about the YouTube, and why I like to promote people like you and Haney and others on my forum and I only put people that I trust, that I stand by. So those are people that I know, that I share patients with, and then it's open, it's live. You can ask us whatever question you want, we'll answer it,
Right.
So yeah, it's really the empathy needs to come out so patients understand. There's so much negativity against doctors in general, medicine, Western medicine, that it's really important that patients understand that it's not real. We're not evil people. We're just human beings. We make mistakes. That happens. But it's not like we're going out to purposely maim you. That's just ridiculous.
Yeah, man, I could inject what you just said into my veins, but I think that it's funny because I had some conversations predating this podcast. So my whole thing with podcasting, I think I've probably talked about this on this podcast before, but I was going through a lot, trying to find a way to get some of my own personal struggles out. And I started a podcast that I've not released. I called it This Too Shall Podcast. Really funny story why I call it that. I'll share that with you if you want to hear it. But so I started that, and I started just talking into a mic. And as you know, it's when you're podcasting, when you first start, it is awkward. Like it is not it's not a natural thing. And so I started doing these podcasts, and it quickly turned into kind of like a mental health focus, because that's a really big thing for me. And it turned into physician wellness. And as I went into physician wellness, I started thinking like, you're talking about how patients respond to you. Even other administrators in the hospital system a lot of them are well-meaning, but they don't understand
Yeah.
And we don't understand what it is to be them. They don't understand what it is to be us. And I'm right now in my career kind of in this weird middle ground where I kind of like fielding everything as the department chairman and things like that, which puts you kind of in this weird position. You're living in both worlds. And I realized very quickly that a lot of times people are saying a lot of the same stuff. Patients and surgeons saying the same thing. Administrators and surgeons are saying the same thing. They just speak different languages.
Yeah.
But at the end of the day, if you translate it, everybody's kind of on the same page, and they all think they're on a different page. And so I one of the points I brought up to our administration was to get approval to release that podcast, which I have yet to do, and then eventually it kind of turned into this podcast. But was to say, I think we really need to do a better job of humanizing surgeons and humanizing leaders.
Absolutely.
And because one of the things that I feel that we get into a situation in medicine that can be really, really dehumanizing and really difficult for the surgeon. There are a whole host of things that can be dehumanizing and problematic for the patient themselves, because I think we're all living in a pretty fundamentally broken system in a lot of ways, and the surgeon or the physicians feel it just as much as the patients, unfortunately. But one of the things that for me that I felt really tough about is that in medicine, from my perspective, the expectation of us is perfection. And so I didn't ever feel the victories of what we do. I felt like I either met expectation or failed, because it was always, and so I had a hard time. I can listen to 100 patients come back to me and say, "Hey, you saved my life," or, "I was at my wit's end with this hernia pain," or, "Hey, I'm back here skiing," or doing whatever it is that I love, or playing with my kids. And I can hear that, and they're like, "Thank you so much." And to me, when I internalize that, I say, right, that's what I'm supposed to do. Right. But then the one person that goes, parking was too far away and the doctor seemed like he was in a rush. And I'm like, I was in a rush. I sat there for 25 minutes, intentionally slowing down. I had plenty of stuff I needed to get to, but I really wanted to make sure that I had that connection. And that one I remember. I forget the 100. I remember the other one.
Yeah.
So whenever you're in those situations where you're getting hammered online for not caring, it's so brutally, it hurts so deep. It really hurts, does. But
I mean, we all have negative reviews, You try and I encourage everyone to make sure that they're very aware of what's online and make sure that they address whatever's negative. If truly there's issues with your front desk, try and fix it, right? A lot of those reviews are about parking and how nice the person was who picked up the phone and stuff, which is important. But some of these things you don't have control over it. But it's very stressful to be a surgeon. I think the older I get, I feel a little bit more daintier about it. I don't like to hear bad stuff. Because I feel like I'm giving up so much of my time and energy to make every single patient feel special and get the best care, that when something goes wrong, right, or they're unhappy or there's anything negative spoken about it, it hurts more. I don't know. I feel we have so much stress, and then you come home and people have family and lives and everything that they have to deal with on top of their surgical life.
Yeah.
Surgery is a stressful job.
It is. And it can be really tough. My own personal experience with getting that kind of hate thrown back at me is one of the things that happened is I was doing my multimodal pain control and it went really well. And it coincided with a big push, a national research questionnaire that the organization sent out. So I ended up doing some national media interviews. And what I found out was that when you start taking clips of what you're saying, if you're taken out of context, you can say stuff that is perfectly well-intentioned, well thought out, and can be very, very misled. People can be very misled by what they think you're saying.
Yep.
And so I was out there trying to promote hey, we just need to do a better job of pain control. Some of these people have pain that we're not addressing, and look at all these other options we can use. We can use all of them together and they can get even better pain control. And I had people that were sending me like hate mail over Twitter.
Dr. Elm says we're not doing good job of pain control.
Well, oh man, the one of them was doctor finds alternative to dangerous opioids or dangerous narcotics. And I'm like, oh boy, here we go. And so I started getting stuff, and people are like sending me like wishing ill upon my family and stuff in the DMs of my Twitter. I like had to delete everything, and it wasn't until so I ended up like basically fading off social media for over 2 years. And it was glorious, by the way. It was I wasn't like doom scrolling. I wasn't like angry every time I got off my phone. But then this kind of came around, and I ended up having to get back on it. So now I've downloaded an app where I have a certain amount of time every day I can be on it, or it makes me do push-ups, squats, or plank to earn minutes to be back on it. And what I found is that my will to be on social media is not as high as my will to be lazy. So I'm just not on social media anymore because I was like, you want me to do 5 squats to be on here for 5 minutes? I don't think so. I'll just
Is that an app?
It is, yeah.
Tell me more.
Yeah, I can't remember. Let me see here.
I may have to start that app.
If they're listening, I'm always available for sponsorships. You know us.
You keep telling me I have to stretch out my legs more.
Yeah. It's called Push Scroll. So
push scroll, okay.
Yeah, and it makes it films. It actually films you, or it doesn't film you, but you have to turn your camera on and do them in front of the camera, and it uses AI to track if you're actually doing them, so you can't just lie. Yeah, so there's some poor app developer that's like looking at videos of me
can you change like how aggressive you want it to control your social media time?
Yeah, and you can like set different things, and it'll let you override. But then when you try to override it without doing it, it makes you take this like really long, slow, deep breath and let it out. And then it goes, "Are you sure you still want to go on there?" And so I'm like, no, okay, fine. But
AI is taking us over.
Yeah, it is.
Telling us what to do, and we need to like feel obliged to do it.
Yeah, I know. We make a few Terminator movies about this, and nobody seems to remember them. But no, I think it's a really interesting thing, and I applaud you for being willing to go out there and put yourself out there, because hernia surgery, like you said, I spend a lot of time talking about mesh. Because of the recruitment for lawsuits, at least here locally, and I'm sure nationally. Yeah. And sometimes, you have to tell them, it's like, listen, it does have risks, and here are the risks, and here are the benefits. And I understand that if you don't want it, then, but the one thing that I think that a lot of people want is they want like a minimally invasive, tap approach. And then they're like, I want it, mesh free and this and that.
I want the shoulder dice for my ventral hernia repair.
Yeah. You're like, well, and so, there's like one of those, there's a lot of things that you end up talking about. And one of the main things that the internet really kind of skews in my patient population, I still do a lot of gallbladders. And everybody thinks that, every single patient that has their gallbladder removed has explosive diarrhea 24/7. Yeah. And I'm like, actually the number is like 10 to 15%. If it happens, it's very detrimental and stuff. But like happy people don't post.
I have patients that are so into like social media and reading, and they're like, God gave me this organ. I don't want to remove any organs. And like literally they have cancer, and they're refusing to have the cancer surgery because they don't want their organ removed. Like it's somehow going to affect their longevity. It's just, you can help some, you can't help others. But I think the empathy and not making them sound like they're stupid or crazy in any way, and just understand that, a lot of what they're really explaining is that they're scared.
Oh, 100%.
And if they can share that there's fright and try to understand. Like patients come to me like, I don't want mesh. So my question isn't like, oh, I can't do it without mesh. My question is, well, why is that? Right? Yeah. Oh, I heard that it's got more chronic pain. Like, well, actually, let me explain to you. That's actually not true. Mm-hmm. So then we go through it. So my office jokes, because there are people that travel from all around to see me, because I do offer non-mesh repair, right? Shoulder dice, Marcy, Bassine, whatever, McVeigh, whatever they need, even robotic. There's some patients that I'll offer it. Mm-hmm. However, there are certain patients that should not get it. A huge scrotal hernia that's been chronically incarcerated, I'm not going to offer you tissue repair for that, Right. Mm-hmm. But that patient will come to me, and travel multiple states at hardship because they heard that I do non-mesh repair. So they come into the room with that idea and they come out of the room and I schedule them for a laparoscopic or robotic repair because you just need to address what they're scared of and then give them the data objectively. And you need to have a reputation that you're honest, right?
Yes.
I'm very honest in what I say. I try and be as clean as possible. I'm not in the pocket of any industry. You know, I don't take, I don't do speaking and dinners and stuff for industry. I've always kind of kept that very distant for myself because I do feel like I need to have that sense of safety and honesty with the patient, right?
Yeah.
Because they look up everything. They will look everything up and read about where you went to school and what these reviews said. And in this forum, so and so said they saw you for a consultation. You said X, Y, and Z. So be honest with them. Give them the data, and listen. If there's a patient that would do almost as well, I'm not going to say perfect, almost as well with a tissue versus a mesh repair, and they understand the risks and benefits of each, and they still choose the tissue repair, I'll offer it. Yeah. I won't do one if I think I'm doing harm, but at the end of the day, it is this kind of like mutual decision making, and this idea that I'm the god and I tell you what happens. Like that's kind of out the door. We don't really do that anymore as doctors.
Yeah, it is a very interesting balance. There are cases, there are some, they're pretty rare actually, that you kind of have to be like, no, I don't recommend you ignore this cancer, like stuff. But I think as I've gotten further in my career, I've become more resilient against criticism from my peers. Because I think as surgeons, many times we are so critical of each other, and we're like, my friend he's a trauma surgeon, and he has a quote. He's like, nobody can F a doctor like another doctor, and and I'm a firm believer that there's no better surgeon than the surgeon sitting in a morbidity and mortality conference with all of the information and the full storyline with someone else's case, right? So then they're like, well, I would have seen that.
Yes.
Yeah. So, but I think that as I've become more resilient to those situations, there are times that I am willing to discuss with the patient less than maybe not my first choice for their treatment, if it means something to them.
Yeah,
so the idea, being, hey, this patient has a breast mass that realistically just needs, in some of my patients, they just need a 6-month follow-up ultrasound. And they're like, listen, I'm losing sleep every single night.
Yeah.
Peace of mind means something.
Yeah.
It really, really means something. I think there's the physical treatment of problems that we do as surgeons, but many times the psychological benefit that we do good for people is much better than any of that. Like I had a patient today who had literally a 7 millimeter umbilical hernia that was seen on a CT scan. The radiologist did catch it, of course.
Yeah.
And comes in and I'm like, listen, this is really, really small. You're a small person. You didn't even know you had it. It's a little finding. Yes, I can feel it. There's nothing in it. It's very small. I said, really, I offered him. I said, this, you can watch this. And the guy's like, I just want it fixed. Like, I'm scared to do anything. Okay, fine. I'm totally fine doing that.
Yes.
There are other people that are like, I'm not touching this until it's like I'm half dead. Like, well, as long as you understand what you're getting into, I'm not here to tell you you're right or wrong. I'm here to tell you, to let you make a choice. How do you handle it when you're in a situation where you may be in a problem where there isn't necessarily one right answer? There's like two not great options. And patients I have patients that like demand that I make the decision for them. Do you ever have that? And if so, how do you handle that?
I mean, I'm okay making the decision for them. I'm okay doing that. After understanding like what's important to them, right? Like, what do you want to get out of this? Oh, I want to be able to go back to my hiking. Okay, laparoscopic repair is better than a tissue repair for that, right? Oh, I can't imagine having anything in me. That's just going to destroy me. I'd rather have a recurrence and then get the mesh in. Sure. In some situations, I'm talking mostly groin. Mm-hmm. That's, not ideal, but that's their decision. And if it's considered like a low risk for recurrence, I'm okay offering a tissue-based repair. But yeah, I mean, there are patients where I think a lot of what I'm saying comes with age and time. I'm okay being the person that makes that decision for them if they can at least give me a little bit of idea of what their wishes are in terms of quality of life, in terms of their tolerance of scars, even, where their scar will be, or how long the recovery will be, like what's important to them.
Yeah.
But I would say, going back to your discussion about your peers and so on, I don't care anymore. Early on, I knew that the way I approached hernia surgery was different than others. Mm-hmm. My patient population is different. I'm a female surgeon. Mm-hmm. It's just different. And there's a lot of people in our world, in our society, that are a little bit more loud, they're a bit more boisterous, and some of them like talk very directly. And I've just learned, like, I'm just not them,
Yeah.
And there are patients that I see that I refer to them. There are patients they see that refer to me, or the patient chooses to like see multiple surgeons and pick one of us. And it's I'm totally okay with it. In fact, yeah. I encourage that kind of back and forth.
Sure.
Yeah.
I've never once in my life tried to talk somebody out of a second opinion. I'll tell you that. That's like
I encourage it. If you listen to me on Hernia Talk Live, one of the things I always say is get a second opinion. It's a surgery. It's not just a hernia. Every person who's had a problem has regretted just quote trusting their first surgeon and not questioning it. You should. Yeah. I myself have had surgery. I know exactly which surgeon I need to go to. I still would go to a second opinion to double check that I'm not missing anything. The questions that I should have asked are all being answered. And I encourage anyone who gets any surgery, no matter how small, to get a second opinion. It's very helpful.
Yeah. Yeah. I go even beyond the surgical decision making.
Yeah.
I go directly because I feel that the relationship between the patient and the surgeon is so critical as far as that trust. And if you're clicking, there have been patients that are like legit. We're in agreement about what needs to be done, but you can tell that we're just not on the same wavelength personally. Like we just like the communication is just kind of like awkward and different. They don't seem comfortable. I'm not really comfortable. And so I was like, would you, if you would like to talk to somebody else, definitely no problem for me. I'm happy to get you somebody.
Sure.
And because I think that, there is nothing, it is going to be a terrifying experience or anything. My wife had 2 major surgeries this month, kind of unexpectedly. And we're both in medicine. We know what's going on.
Yeah.
It's scary. It's still scary.
Yeah.
and so if it's scary for us, think what it is for people that don't know all the safeguards in place. And so those types of things I take very seriously. One of the things you brought up was you have a little bit of a different patient population. You focus a lot on female patients that's your patient population. And so you're kind of focused heavily on those. My wife, who has gone deeper and deeper into menopause specialty, she has, really enlightened me to the dramatic differences between some of the data out there and how it doesn't necessarily always accurately represent women, and how some of our
FDA changes on vaginal estrogen. Yeah, absolutely.
So, and in some of the historic studies that we still use for treatment as like the dogma and where we kind of move our rest of our treatment strategies from, may have very narrow scopes of the diversity of the patient population that was studied. So when it comes to hernia surgery in general, what do we get wrong about hernia surgery in women?
Well, the same way medicine kind of treats women is like what we call bikini medicine. It's either a breast issue or it's like a gynecologic issue. And all the other things, colorectal, heart, even hernias, are mostly like male-dominated studies, male, and so on. I think we treat women's hernias the same. So we think that women present the same way, which they don't. We just published our paper that shows the very different symptoms that women present with versus men for the same, quote, inguinal hernia. This kind of over study of femoral hernias, saying that, like the European Hernia Society guidelines say, because women have a higher risk of chronic pain after inguinal hernia repair, and a large proportion of those, I think 30-40%, are because of missed femoral hernias. Therefore, all women should get laparoscopic hernia repairs. Well, what does that imply? That means all women should get a mesh-based repair. Yeah. That is not good for women. Women do not need mesh-based repairs. They tend to have smaller inguinal canal, smaller hernias. Marcy has been shown to be perfectly good for these really small hernias. Some women do better with a tissue-based repair. There's more nerves in the pelvis. There's more concentration of nerves in the pelvis. That's been shown in anatomy. So mesh causes inflammation. Women have more autoimmune disorders. Mesh is not a good idea in those women. So tissue repair should be more common in women than men. But if you follow the Hernia Society guidelines by the European Hernia Society, laparoscopic repair should be the gold standard for women to reduce the risk of femoral hernia, missed femoral hernias. But that implies every woman should get mesh. So it's this poor understanding of how they present. Women are going to have more pain during their menses. That doesn't mean they have endometriosis. That could be a hernia. Women are going to have pain with intercourse. That's not a gynecologic issue. That could be a hernia. Women are more likely to have pelvic floor spasm and the downstream effects of that, besides pain with intercourse, urinary frequency. Don't send them to urologists and get them worked up for interstitial cystitis. They probably have a hernia. So there are all these things that men don't necessarily present with that women do. And women don't have this big hernia. Most of the time, it's usually small or more difficult to diagnose, and it's more subtle. And because you can't necessarily see a good hernia in a lot of these women, you label them with chronic pelvic pain and you send them to pain management or the gynecologist that treats them for chronic pelvic pain, Voltini and all this other stuff. So by treating these women and then getting a good relationship with my gynecologist and urologist, and then my pain doctors and my radiologist, I've gotten to learn how different women are. And it's just not cool when I look at my patient population and they're misdiagnosed, delayed diagnosis, and much more likely to have opioids diagnosed before they ever see me. That doesn't happen with women. Same thing as with heart disease, right? They're more likely to be given pain medication and sent away and told they're just, anxious when their chest pain is not exactly the way men present. So I'm hoping that we will have watchful waiting trial for women. We don't have one yet. University of Michigan is, I think, either got their NIH grant or applied for their NIH grant to study it. I hope to be involved in that, to actually enroll patients in that, because we need to understand whether watchful waiting is appropriate for women. Currently, it's not. Why? Because we may be missing femoral hernias and people die from missed femoral hernias. We don't understand what happens with pregnancy. If you have a ventral hernia or umbilical hernia in a woman, if she's not done with her pregnancies, probably shouldn't repair those yet, right? That's not a discussion we have with men. It's really a discussion that we should have with women as to how symptomatic they are and where they are with the pregnancy. Gynecologists want to fix a belly button hernia during their C-section. Don't do that. They want the hernia fixed during the C-section. Don't do that. Wait until they're done 3 months after their last, 3 months after they deliver, or 3 months after they're done breastfeeding, whichever one's later. That's when your abdominal wall is different. So hormonally, it's different. Scars are different, right? Women like to be midriff bearing. The scars may be more important for women than men, and diastasis may be more important for women than men. There's so many little intricacies that you should think of when treating women that doesn't really fall into your algorithm when treating men, that I hope one day we will be a bit clearer about all this. To me, it's natural now. Like, I don't think twice about it.
Yeah.
And so when I just rattle it off, it's like easy. But, I think the average surgeon doesn't appreciate that yet. And hopefully, as we publish more and write more book chapters on it, then maybe eventually it'll get into medical school and people will kind of learn about this. Because it's not just a surgeon issue. It's the family doctor, the internal medicine doctor understanding that this chronic pain is not a gynecologic problem. And the gynecologist understanding it's not a gynecologic problem.
Sure. Yeah. No, I think that even those of us that take care of hernias, I think that even us that are well intentioned, because there aren't the studies, and because we don't, probably because they're just not being referred to us because they're being mislabeled. We don't see as many inguinal hernias in females as are out there, and so that experience and that seeing the reps over and over and over again, it just doesn't happen. And so, I feel like I should bust out a notebook and have you say that. I'm going to go back and listen to this later and take some notes. But no, I think we've got, we have a Whitney Palmer Hospital here is an enormous, 14,000 deliveries a year, I think it is. And so, we see a ton of those. And just talking with people, the number of women that are sitting out there with rectus diastasis, where they, these are otherwise fairly fit ladies who have a hard time sitting up out of bed. Yeah. And it's just completely ignored because it's just, I had the babies and this is kind of the one I was left with. And, you see them and you're like, we can do something about that. If it's really, if your core is that unstable and you're having that much problems, they half the time they come to me for chronic abdominal pain. They're going, is it their gallbladder? I'm like, no, it's because they've got this massive colon full of stool because they can't generate any abdominal pressure to have a bowel movement.
Yeah, compensation due to absolutely due to diastasis for sure.
Yeah. And then you only do a few of those. You only do a few of those cases before you realize that you really need to make sure they're not constipated prior to the surgery, immediately prior, because then the recovery is really difficult because they're all this pain. And then the connection between pelvic floor dysfunction and diastasis and how all of that kind of molds itself together.
Yeah, it's all the same family, and you can treat a ventral hernia, even an incisional hernia, with a tummy tuck. Or you don't have to put mesh in everyone. Putting mesh has its risks and benefits, and we had this discussion a long time ago, and I said, you really, when you do these TARs or ETAPs, you really should close the posterior fascia, and they're like, no, you don't need to. And I'm like, or you shouldn't. I said, literally every patient that I do, I close it. Now, it'll be rare, and I tend not to have 20-centimeter patients. I'll grant you that. But, the 10, 12, 15-centimeter hernias, do your dissection so you can close the posterior fascia. You don't need to do that. And I'm saying, what you're not understanding is that's your transversalis fascia. The transversalis fascia is the inner girdle. If you don't restore your inner girdle, you're going to get a boxy belly. It's going to be like a box, like a square. And if you're operating on patients that are somewhat, overweight or obese, you may not appreciate that. But a lot of my patients are not obese. And if I don't close that posterior fascia, they're going to be very unhappy with this kind of boxy look to their belly. And now all of a sudden they're like, oh yeah, we should consider doing it. But because I'm more of a pelvic person, not an abdominal wall person, no one listened to me until now that they're seeing this more often. They're seeing the change in contour and how important that posterior fascia is, that people are starting to do it. It's you just learn over time. And at my LA County job, I was very young when I started compared to everyone else there. I joined a very old, everyone was over 70 among the faculty. I think we had one guy who was in his 60s. And then I started there and I was 29. So I was like their grandchild, basically. But the beauty of it was I was surrounded by really experienced surgeons. They taught me stuff that they learned in the 50s, 40s, and 50s, right?
Yeah.
That we don't know anything about. And we've lost like the history of hernias and the history of surgeries. We've lost it.
Yeah.
But they taught it to me, and I learned, and they gifted me books from during their time. And I learned so much from them. And I see our younger generation of hernia surgeons, which is so awesome that we have so many really gifted, talented surgeons joining our hernia society. But some of them are cocky like I used to be cocky when I was younger. And they think they know what they're talking about. And I'm like, no. What you're saying, we did 40 years ago, 50 years ago, 30 years ago.
Yeah.
Let me tell you, that's not how to do it.
Right.
And they think they're like being so innovative. And, we don't want to repeat history.
Yeah.
And what I liked about the IHC and many of our hernia societies is we are in general a very kind family of international doctors.
Yeah.
That's why I go to the European Hernia Society meeting every year, because I love hanging out with people of different countries and learning how they do things. And we're pretty nice to each other, We refer to each other a lot. We share a lot of patients. I offer what's called an online consultation.
Yeah.
I know most people can't travel to Beverly Hills to see me. But maybe I could help them in some ways. So I do offer like an opportunity just to review their story and guide them. And I'll say, and then go to Florida, Dr. Tokla is there, and they're like, oh, I didn't know that, one city over, let's say.
Right.
And that way you kind of share the love, right? And kind of allow patients to get good care within their community. And, what comes around goes around. I strongly believe in that. So that's the beauty of hernia family, I call it. I really like our group of people.
Yeah, I've not been deep into other subspecialties, groups of people. I know some that I can just intuitively guess some I wouldn't want to be a part of. But hernia has been a very beautiful surprise, and everybody that I've had the opportunity to talk with,
yes.
I've been really lucky to have the opportunity to talk with some very well-known folks such as yourself. And everybody's I think the thing is crazy how everybody is so humble about everything, yet not much to be humble about, or like not. There's no reason for them to be humble. They have all the reason in the world to be extremely arrogant and cocky because of how good they are at what they do and everything. But yet they're still so humble.
Every single one of them is helpful. If you call up any one of those people that you may even think are cocky or whatever, every single one is kind, helpful, will go out of their way to guide you and make you a better surgeon.
Yeah, no, they're not cocky at all. And I'm just sitting there going like, you realize who you are, right? You could be cocky and nobody would blame you for it. Like everybody knows who you are. It's amazing, and then they're just so down to earth and so willing to talk about their failures.
Is not I mean, this is Hollywood, right? Yeah. So it's not like being a hernia surgeon is like you're being like someone in the street's going to notice you. That doesn't happen.
Well, it happens when you're
around my office. I'll tell you that.
Yeah, but I'm sure at the EHS people know. You know what I'm saying? It's all relative.
Yeah, exactly.
No, it has been a really good a good thing. I've had the absolute pleasure to talk to quite a few female surgeons, a lot of which are in Europe, and they all have their own stories, and obviously the surgeons in the United States and other countries have theirs as well. But I think that there are definitely some hurdles that females in the surgical community have to overcome, unfortunately, in a lot of cases. And how have you felt about your journey? And do you feel like the current situation, are we moving in the right direction when it comes to embracing females in surgery?
100% moving in the right direction. My first American Hernia Society meeting was in 2002. I opened up the door I think it was in Orlando. I opened up the door to this space, and it was like a sea of white hair or bald-headed men, and I was like, oh my God, because as a resident, I was pretty prolific, and I'd gone to a lot of different society meetings, present my research. That was not my understanding, and I was like, oh my, am I the only female? I think there was one other female, not even joking, to the point where, remember, I just graduated. I didn't do fellowship. I went straight from residency to job. And I gave my talk. He came down, and Chuck Philippi, who past president of the American Hernia Society, he was editor-in-chief of the Hernia Journal at the time. I had no clue. Comes up to me and says, that was really great. Would you like to be one of our editors in the Hernia Journal? I was like, me? He said, yes, we've never had a female before. And I said, hell yeah. Now, I had no business being any part of any journal. I was like 4 months out of residency. But it just showed how wonderful and kind it was for Philippi to do that. Mm-hmm. And then I got a position on the board, so that helped. And now we're at a point where the next several, presidents are female. We have the Hernia Surgeons Alliance, which is like a female-oriented alliance of younger generation of surgeons that are all female that are hoping to promote more research and education and interest in female-based stuff. I would say about 6 or 7 years ago, I started a grant at the American Hernia Society. It's $2,000, right? My own money that I gave. And I said, this has to go to any research, the top research that specifically looks at female factors in hernias, right? No more of this like male-only research. Mm-hmm. And I thought if I throw money at it, then someone will want to write a research project or an abstract to the society meeting. And I think the one who won the first one, it was the only abstract. So there was like no competition. But now there's actually competition. Multiple abstracts are submitted that look at female factors in hernias. And, it's like a somewhat competitive, award to win at the American Hernia Society. So each of us is doing our part to promote it, and hopefully that'll infiltrate into the general public too.
Is it still the $2,000 grant, or is
$2,000?
Is there a way to
make 2,000?
Is there a way?
High quality abstract that specifically addresses female factors.
Well, that's one thing, but how do people that want to get in on that action help support the grant?
I mean, I'll take donations. I do have a foundation. It comes from my foundation. Mm-hmm. So I do have the Beverly Hills Hernia Foundation. It's a 501c3. If you ever need to put some money away as a tax donation, feel free to donate. It's on my website, beverlyhillsherniafoundation.org. And 100% of the money goes towards supporting research and education in hernias, including the grant that goes to the American Hernia Society Foundation.
So if they make a donation to that, can they earmark it for that grant? Up the stakes a little bit. Let's get it. Sure. Let's get it going.
Bring it up. Yeah, let's do it. We can you know what? Why not? One day we'll have an actual research grant of, let's say, $10,000, $20,000. Specifically aiming at that kind of research. Absolutely, we should.
It's a big deal here in the Elms household with my wife's interest. It would go a long way towards getting me out of a lot of trouble that I get in frequently. So.
Yeah, let's do it. That's like the legacy I want to leave behind, because eventually I have to retire, is that hopefully I've been able to kind of shift the understanding of and improve the care given to women in hernia.
All right, so we're going for what? We're going for 10,000.
Sure.
We're at 2,000 now.
I think it's 10, 20, and 30. There may be a $30,000 grant that's currently there. But yeah, we can start at 10,000. Sure.
Let's shoot for 10. I got 1,000 towards that right now.
Okay.
So we'll go 1,000 there, and then the listeners, let's do it. Let's get it up to
10,000. How's that?
Sounds good. Well, I mean, you've kind of already matched double that. You're making me look bad now.
On top of that.
On top of that, excellent.
Excellent.
Yeah, no, we've had some.
4,000 already.
Let's do it.
See how easy that was?
We're almost there. So let's see. We got to get somebody that we know is just made of money. Let's see. If we knew somebody maybe that practiced on Fifth Avenue in New York, that might be somebody that
like
might we could
around Central Park across from
right around there.
Park on Fifth Avenue.
I think that would be somebody that could probably do something with that.
I'm gonna have to have pride about that.
Yeah, well, maybe he'll know somebody. Well, it's been an absolute pleasure talking to you. I've been looking forward to this discussion for a while, and flattered that you would take the time and come on the podcast. As we kind of come towards the end of an episode, every time we do the hernia hot take, which I shamelessly stole from Hot Ones. I'll tell you that right now. I love that YouTube channel. Yes. But the hernia hot take. So if you have your opportunity here for your opinion on hernia surgery.
My opinion on hernia surgery?
Unpopular or popular or otherwise?
My opinion is that we will eventually have a scoring system that will make it even simpler to understand who has a hernia and what kind of treatment they should get. Because even diagnosing is hard, even for like ER docs, and the same we have like the Alvarado score for appendicitis and all that. My prediction is we'll have a scoring system. You fill in all your symptoms, right? AI was going to help with that. It tells you which surgery, whether you have a hernia, and that's the cause of your groin pain, let's say, and not your hip or your back or whatever. And then based on the information you feed it, it'll tell you what are your best options and the success rates for each of those.
That's fantastic. You know what it sounds like? It sounds like a good way to get a $10,000 research grant once we hit up our friends in New York. So no, that's great. Again, thank you so much for coming on. It's been a pleasure. Obviously we could take a lot from your presence online and how you connect with your patients and the passion you have for treating all patients, including those that are painfully underrepresented in the treatment algorithm. So it's been a very much a pleasure talking to you, and hopefully we can have a conversation again in the future.
Thank you so much, and you have to promise to be the guest on my podcast.
Anytime you let me know.
You do I would be honored. That. I really enjoy listening to your other podcasts. The humanity and caring that you have, and the stories that you extract from people is fantastic. So congratulations on your podcast.
Well, do you want to hear one quick parting story about why I named my other podcast, this Two Shell Podcast? Yeah. My wife and I got my first job offer, and so we went out to celebrate. And I'd had a couple of Corona Ritas. I don't know if they have those in Beverly Hills, but out here in Florida, that's a Corona turned upside down in a margarita. As we were celebrating, okay. Yeah. And so we go do we're sitting there, and I'm thinking, I'm always in my head living in the future or in the past. And I said, this too shall pass. That motto, it really means, not just get through the bad times, but really cherish the good times, because even those are going to pass. And I'm, pontificating a margarita and a half deep, and and I was like, you know what, I'm going to get that as a tattoo. My wife has tattoos all over her torso, and she's just like, you're always seeing that. I was like, I'm going to do it, and she's like, no, you're not. And I was like, no, I will. And she goes, no, I think and then she's a gynecologist, so she says a word that's for her, but I won't repeat it here. But it was a derogatory. She meant it in a derogatory way towards me, and and I said, fine, I will. And she goes, good. She picks up the phone and calls her tattoo artist. She goes, he has availability right now. And I'm like, uh-oh. And so an hour and a half later, I'm in a tattoo chair, and I'm getting this too shall pass tattooed on my chest. And so I have it set up right here. And I'm sitting there, and I'm getting myself hyped up to get this done. And she's just like, it looks dumb there. And I'm like, well, what do you mean? She's like, it looks dumb. It needs to be moved. I go, we'll just move it and make it look good. So she moves it. She takes it from here and she moves it here. Uh-huh. And so I get the tattoo done. And I'm on my way home, And I send my buddy a picture. He's a urologist. I send him a picture and I said, I said, why? I said, check this out and everything. And he goes, bro, go home, put on scrubs, take a picture and send it to me. I'm like, okay. So I go home, put on a scrub tops or V-neck, and I take the picture and I send it to him. And it turns out that when you wear scrubs, all that shows is ass. and so I go to work the next day, and I was the administrative chief. And I'm like, you know what? So I wear an undershirt, and I'm a husky dude, so I was like sweating. So I go in, and we have a resident meeting, and I'm running the meeting, and I take off my undershirt before in the locker room and just put on regular scrubs. So like, if they don't say anything, I'll be fine. So I go, okay, everybody calm down. Okay. And then I go, okay, so, and boom, hand goes up.
Oh my God.
Yeah. And he goes, hey, why does your chest say ass? And I was like, so that's my story of how the other podcast got its name.
Oh, that's good.
Yeah.
Oh, wow. That's a great story.
I wish I didn't have so many of those embarrassing great stories.
That's great. Now, does your wife feel guilty about how she positioned it?
Not at all.
No.
She thinks she takes every opportunity to make me look like an ass.
So, I love her. I need to meet her.
Yeah, she's a very powerful person. So, and our daughter's taken right after her, so it's good. But patients love it, though. It's very humanizing for the patients. So
yeah, I get it.
They comment. I don't wear an undershirt anymore. I'm like, if that's going to make you not choose me as a surgeon, you probably need a second opinion. So, but anyway, so that's the way where that came from.
Great.
So, well, I appreciate you again coming on. Thank you so very much, and can't wait to have a future discussion.
Yeah, looking forward to seeing you again.
All right, thanks. Well, this wraps up another episode of the Hernia Gods Podcast. This is your mere mortal host, Luke, signing off. Thank you.